Assalamu alaikum and welcome to another video on ECG. I am Dr. Wajid Chabir and I have done residency in cardiology. This is the ECG which we are going to discuss today. This is ECG of a 52-year-old gentleman who presented to outpatient department. Before starting the discussion, as always, pause the videos, note down the findings and diagnosis with yourself, and at the end of the video, compare your findings and diagnoses with what was discussed in this video. So let's begin the discussion on this ECG. As you know, the first thing which we look at on an ECG is rhythm. As you can see that at the bottom of the ECG there is a rhythm strip in which there is a prominent P wave before each QRS complex. So this is a sinus rhythm. After that, we are going to find out the heart rate. Today, to calculate the heart rate, we will use formula heart rate is equal to 300 divided by number of large squares between two QRS complexes. First of all, we will select two QRS complexes, and then between these QRS complexes, we will calculate the large boxes. As you can see that there are 1, 2, 3 and 4 large boxes between these two QRS complexes. So to get the heart rate we will divide 300 by 4. So 300 divided by 4 will be equal to 75 beats per minute. So this is a sinus rhythm at 75 beats per minute. After the heart rate, the next step is finding the axis on an ECG. For axis, we will look at lead 1 and lead AVF. As you can see that in lead 1 the QRS complex is positive while it is negative in lead AVF. So the presence of a positive QRS complex in lead 1 and a negative QRS complex in lead AVF means that it is a left axis deviation. The next is P wave. You can see that in lead 2 the P wave, although it has a low amplitude, but wide it is wide and notched. Similarly, in lead V1 it is biphasic with a negative terminal which is more than one small square wide and more than one small square deep. So presence of such P waves in lead 2 and V1 means that it is a left atrial enlargement. After the P waves, the next step is looking at QRS complex. It is evident that the QRS complex is slightly prolonged with duration of QRS complex around 3 small squares or 120 milliseconds. Also, another prominent findings which you can note is the presence of R wave in lead V1. Normally, in healthy adults with properly placed leads, we do not get a R wave which is more than S waves, more than or equal to S wave. There are multiple causes of prominent R wave in lead V1, and we will discuss them one by one. Firstly, prominent R waves in V1 can be present in healthy children, but in that case the duration of QRS complex is usually normal. The second cause of prominent R wave in lead V1 is presence of right ventricular hypertrophy. In case of right ventricular hypertrophy, we usually find right axis deviation or vertical axis. But here in this case, as we discussed earlier, that the axis is left axis deviation. Also, in cases where there is right ventricular hypertrophy, the right precordial leads, that is lead V2, V3, they have T wave inversion, which is not the case in this ECG. So, right ventricular hypertrophy is less likely in this ECG. Another cause is presence of hypertrophic cardiomyopathy. But in case of hypertrophic cardiomyopathy, we usually find left ventricular hypertrophy as well as deep T wave inversions. In absence of these two findings, rule out the presence of hypertrophic cardiomyopathy. Another reason for prominent R wave in lead V1 is Duchenne muscular dystrophy, but this patient did not have any such history. Next is the presence of right bundle branch block. Although there is a wide QRS complex in lead V1, but if we look at lead V6, there are no deep S waves. For a right bundle branch block, there should be RSR pattern in lead V1 with deep S waves in lead V6. So this is not a typical morphology for right bundle branch block. Rather, we will call it interventricular conduction delay. Now, another important cause for prominent R wave in lead V1 is presence of ischemia. If we see in lead V6, we can note that there are small Q waves in lead V6. Similarly, there is presence of Q waves in lead 1 and AVL. As we know that the presence of Q waves on multiple leads in ECG, they indicate previous myocardial infarction. The presence of prominent R waves in lead V1 along with Q waves in multiple leads as well as upright T waves in lead V1 to V3, they suggest the history of ischemia and probably involvement of posterior wall. In the next step, we look at the ST segment. As we can note that in all the chest leads as well as the limb leads, we do not find any ST depression or ST elevation. Similarly, the QT interval, that is a duration from beginning of Q wave till the end of T wave, it is within normal limits. So this is all for today. Hopefully you like the video, you learn from it. For more videos, kindly subscribe to this channel and stay tuned. Thank you and Allah Hafiz.